Good evening, everyone. Welcome to the Doctors in the House Health Show on 99.1 FM, WUJM, St. Petersburg Community Radio. We have an excellent program for you tonight. Please stay tuned. Good evening, everyone. How are you doing today? How are you doing? Welcome to the Doctors in the House, your health show. I'm Dr. Morency, your host. You're listening to 99.1 FM WUGM St. Petersburg Community Radio. And for those of you online, www.99gemtheberg.com. Welcome. And if you have any questions, please call. We are at 727-637-2416. The topic tonight is non-drug options for depressions, meaning you don't have to take a pill to treat depressions. On our last show, about 2 months ago, we talked about how you as a person can identify whether or not you may suffer from major depression versus having the blues. And this is all going to be has been based on what kind of symptoms you feel. And we talked about certain criteria, how you can arrive at the diagnosis. So today we have a different program because, as promised, we're going to talk about treatment options, okay? Because I had promised you the last time that after you make the diagnosis and give you a taste of what kind of treatment we usually use. And we have today the privilege of having a young professional who treats mental illness, including depressions, for a living. So we're going to have the right answer tonight. And so before I bring her in, I feel kind of obligated to quickly recap what we've talked about 2 months ago. I hope you remember or you've done a little bit of research since then. Very, very important. Major depression is a serious illness with deadly consequences. Ergo, suicide. And it's also a cause of serious disability. Probably the number one cause of disability around the world. What depression is not a sin, it's not a weakness, it is not a choice. It doesn't make you crazy. Hopefully you remember some of this, okay? So what we talk about is essentially for you to make the diagnosis yourself, to have an idea really what is, how do you feel? What does depression make you feel? And for how long? Remember? I said there's so many symptoms, people can experience that it's really difficult to count. But in order for us to really navigate to this, of all the symptoms, there are two big symptoms you have to have in order for us to be in the ballpark of major depression. The key symptom is when you lose interest in any pleasurable activity, anything you used to do, a hobby, you enjoy something, your family, and all of a sudden, you have absolutely no interest in any of this stuff, including sex. The second symptom, which is very important, having a persistent depressed mood. So you have to have one of those really to start talking about depression. And then of all the symptoms that we talked about, you can add 5 more symptoms to be included in the pursuit of the diagnosis, from sadness, anxiousness, feeling empty, tearfulness, big stuff, definite alteration of your appetite. You can either eat too much or eat too little. You lose weight, you gain weight. Sleep problem is a major problem, okay? Sleep disruption, and sleep is very important anyway, but sleep disruption make us think of depression. Too little or too much, early morning awakening. Energy. Decreased energy, the energy vampire zap you. You feel fatigued, you feel like slow down. On the other hand, you could also be totally restless, irritable, cranky. Some of the emotional symptoms, psychological symptoms, guilt, you feel helpless, you feel worthless. Pessimism, you have trouble concentrating. So you see there's a whole series of symptoms. Not everybody experiences this thing, but this is the menu, okay? And one of the big symptoms, if you begin to think about suicide, killing yourself, hurting yourself, that's a biggie, okay? And then for me as a primary care doctor, it used to be people come in with physical symptoms. They have headache, chronic pain, neck pain, back pain, dizziness that never goes away, plus the fatigue. So usually it would alert me to definitely give the patient, you guys, a questionnaire so we can find out. Okay? So now, does having all those symptoms make you having a serious depression, major depression? Not necessarily. In order to really qualify for major depressions, the symptoms have to last at least 2 weeks consecutively. Okay, because if you feel good a certain days and the other day you're not, you can have the blues, but not severe depression. Even then, with all those things and the duration, if you don't have any impairment, if you feel you can go to work, you've been going to work, you've been carrying your normal duty, you just feel lousy and bad, it may not necessarily rise to the level of the disease. Okay, so some impairment where you are unable to perform your normal duty at work, at home, you just stay in bed, vegetating and not interested in anything, that's serious. That's really, I hope you remember, this is how you can actually say, well, I may have major depression, like the doctor said, let me get some help. Well, we're going to discuss today treatment options, okay? And again, let me begin by saying, in any cases, depression can be effectively treated. And the earlier we start treating depression, the more effective it is. And it is usually treated with medications, psychotherapy, or combination of both. We're not going to talk about medication today. We don't have enough time. And I am going to take advantage of this young doctor here who is in practice and treating all this stuff to really kind of zero in on some of the therapy and other modality of treatment. It is my pleasure, great pleasure, to introduce to you Dr. Brittany Peters. Doctor, welcome.
Thank you.
And thank you for taking time out of your busy schedule. I heard you're a busy lady to come here and share your thought with the patients, okay? So why don't you start by telling us a little something about you?
Well, I always like to thank you all for having me. It's always a pleasure to come and talk about all things mental health, especially minority mental health, because we don't talk about that enough.
It's a taboo.
Right? Yeah, a taboo and a stigma, and so I can appreciate that. And then also, I wanted to always think I love this city. I am not a St. Pete native, so I have only been in this area for about 5 years.
Okay.
I'm originally from Tallahassee, and so I love it down here. And so I have to say thank you to the listeners, for creating.
St. Peter's changed.
Yes, it has changed. The food is good. The people are good.
It is more accepting now of the young folks.
Yeah, I would say so. So when we start to talk about coping skills and different things, I always feel like there is a lot within the city that we can suggest and a lot of supports. Mm-hmm. And I try to get out and get involved in the community here so that I do know those things, and so that when I'm working with people, I can make some suggestions for supports that are really for them.
I heard you are the owner of the wellness center.
Oh, yeah. Let me not forget that, huh?
Please.
I guess that's important. So I operate a practice in Pinellas Park. It's the Center for Wellness and Clinical Development. And so a large part of my practice is developing clinicians and preparing them to be able to work with Black and Brown. Okay. And that's through CEU training and clinical supervision for therapists.
So a teacher, a mentor.
Good I like
to
say that a little bit. And then also working and providing therapy to those who are in need. So that's what we do.
The problem with this show, this time we have here, time has a way of flying. So we made her try to get to the heavy-duty points so nobody can accuse us. So what I wanted to really concentrate today as a therapist, essentially, when you have somebody, so I send you somebody who I believe has depression, they meet the criteria, the thing, and you evaluate them and you agree that they have major depressions. So what's your next step, or how do you approach a new client with depressions that's confirmed, and that's also agree that they have depression because they have to agree.
Yes. And I heard you going over the symptoms and talking about the PHQ-9, right? And that is a really effective tool that we can use to identify the presence of major depressive disorder, right? But it also helps us to identify the presence of mild and moderate symptoms of depression, right? And so it's always important that we get that early. And one of the first things that I usually do with my clients is to get a little background information from them.
Of course.
And to talk with them about what life generally looks like. So I heard you say that, most days than not, they would have these symptoms that are present, which is correct, right? But we want to know, what does life look like when they are not experiencing these depressive symptoms, right? Were there any recent triggers? And so I try to get a range of their history, right? I'm not just doing a PHQ-9, but I tend to do an adverse childhood experience assessment with them as well to identify the presence of trauma and to see if there's something new, because as you said, these symptoms can come and go, right?
Correct.
So we have a bit of adjustment and a normal bit of depression that we feel at normal life transitions.
Absolutely. Lots of people have this mood swings.
Right. But when it starts to impair functioning, as you mentioned, right, when we are no longer going out and playing the piano, if you like to do that, right, you're no longer spending time reading or spending time with your friends, right? Maybe you are not eating and it's causing you weight loss, right? That now is of clinical concern.
And you're not sleeping, you're drinking instead to sleep.
Oh, yeah. And sometimes that's how I do get clients, right? Sometimes it's the substance use, right? I'm not depressed, yet I drink every night to sleep, right? I'm not depressed, but I'm smoking every day, right?
Yeah, absolutely.
And so we want to figure out what that looks like. And so there are a couple of things that I try to work with my clients on, because I know we don't have time to talk about medications today, but what I will say is that medications are great, but when you do that in conjunction with therapy, you see symptom reduction. That is a little better, right? We want to see clients able to apply their coping skills, right? And so when we talk about therapy, people go, well, what is that? That's just like telling someone your problems, right?
I don't want to tell people
I don't
my
want to tell my
problems.
problems.
That's none of your business.
What is that going to do for me? Yeah, right? Or I got my own circle.
I thought it was just the primary care physician who goes through this. So you, as a therapist, you get that too.
Yeah, I get that. Like, why do I need to talk to you? And so one of the things that I think is one of the most important parts of therapy, right, is helping you to identify any automatic thoughts that you have that may be contributing to your depression, right?
Talking about CBT.
Yeah, we talk about cognitive behavioral therapy there, yeah. And and people struggle sometimes to identify their automatic thoughts because they are automatic, right? I happen to do everything so quickly, right? So I'm snapping here at my fingers because that's how quick our thoughts can run for us sometimes.
Absolutely.
And so therapy helps us to kind of slow it down, right? And really think about, well, tell me what happened and what did you think, right? And then what was that emotional consequence? Because that emotional consequence led to the behavior, right? And so if we can change that, and that's what therapy does, right? How can we challenge some of those automatic thoughts? How can we reframe them, right? So that they result in more productive behaviors overall in symptom reduction.
Let me ask you this. Do you have an agreement with the patient before you really start the therapy? Do they have to sign up or at least agree to follow your...
I think that for my clients, I always told them that the agreement is with themselves. They're agreeing to invest in themselves, right? So yeah, we have our paperwork, we have HIPAA reminding them that everything we talk about is confidential, and we do a treatment plan with them. But really this plan, really how I like to frame it is, what is it that you're wanting to work on and willing to work on? Because we know a lot of times people are not always coming into therapy because they are fully ready or vested, right?
Correct.
But they're always invested in themselves, right? We're just figuring out how we can tweak that, right? And so how can I get you to see that there is a value to you in working on you in this moment, right?
Well, therapy is hard work.
Yeah.
I mean, people would think that especially with cognitive behavior therapy, you have to do homework and exercise and pay attention to your thoughts.
You're using the wrong words. We don't call it homework, right?
Oh, sorry. I am old-fashioned, so that's what happened.
But you are right? You're very right. And so I think that we get creative in our labeling, right? Because people don't like homework. You have kids, and kids don't like to do homework it is taboo. I don't want to do that. It sounds like a lot of work.
That's why I have you here to translate for me, okay? I don't want to be a professor to those people.
Yeah. So we want to find, what are we doing outside of the session, like you said, right? Because you can't just do the work while you're here.
Correct.
You have to do some things after. And so I talk to clients about different things, journaling. I always share that I'm a pro journaler. I journal all the time. I journal my prayers. I journal my budgeting. I do a lot of journaling, but something different for each person, right?
Actually, there's other function of journaling. When you write it down, it tends to happen. Yes. There's a book about this.
It helps you remember things when you write them
You
down.
write it down. And sometimes you just go back, to flip and to see where you are, what progress you made. So that's very important.
Yeah, and that's why we have them write down their automatic thoughts, right? Like, what came up? I want you to write what comes up for you. Just jot it down for me. What I love about the digital age now, though, is that you'll find that you can encourage clients to do it in different ways, right? So now I tell my clients, I'm like, look, if you don't want to write in a journal, what about your talk to text? Can you write notes on your iPhone, right? How can we get creative with that? Do you want to do a voice memo? What do you utilize? What are your strengths? What are the things that you're good at that we can utilize to help you to invest in your mental space, right?
So what percentage of people actually believe in being treated for depression that's going to do anything as far as your populations? And
I think it depends on the population. There is for Black and brown individuals, we don't seek out therapy.
Correct.
And in the same manner in which our European counterparts do, right?
Correct.
So it's interesting is that I was prepping for something else, and I was talking to Brother John, who we were on the show with him a month ago, but I was doing some work and. There had been a recent study published where the CDC had been looking at rates of depression, and they used the PHQ-9, right?
Correct.
And so they were looking, they do this study every year. It's the State of Mental Health for America. It's a nationwide study, right? And so we know that historically African Americans don't participate in these studies. And so I believe 2019, the amount was about 33,000, right? But last year during COVID, we had about 90,000 African Americans in this particular study. Pretty good,
COVID
right?
COVID was devastating.
Devastating, right?
Yeah.
So what came out of that is from February to, I believe, September, where they were drawing their data, 77% of that population who participated in the study, African Americans, identified having depressive disorder, right?
Yes.
And that is significant to see, right? Because we're close to 100% there. This is very high. And so what we want to look at is, while we're saying, how many believe in it, I think we're increasing the number of people who are willing to say, I'm experiencing the symptoms.
The word's been out there a little bit more, and the pandemic has certainly opened this thing up.
Yeah.
Because in the past, we find it out when it's too late. People committing suicide and the drink and the drugs and disaster. And the physical thing. The slow suicide is the person who doesn't take care of their diabetes, they don't take care of their hypertension and their heart disease and stuff like that. Yeah, well, yeah. I've been in the front line. I know this stuff.
Right.
And that's why in primary care, if we're not going to be able to really tackle this stuff just in primary care because it is not quick. And having a test, and the difficulty with depression is that you don't have a laboratory test to make somebody believe the number is 75 or something.
Or that the symptoms exist, right? That they could be overeating because they're depressed.
All those secondary things we have to be clever to discuss. I used to ask my patients, this is one of the things when I trained in New Jersey. He said, even the primary care physician, because we use the SOAP format, subjective, objective, and plan, that's what we document our note on medicine. But for mental health, we use something called the BATH, background, affect, background, what's been going on with your life.
Yes.
Okay.
Yes.
How does that make you feel? Okay. And then the patient certainly would open up with 100 million things, and then you would tackle the most important thing. You said, of all those things, what trouble you the most?
Mm-hmm.
Okay? And then the H is how you ask the patient, how do you handle it?
Yeah.
Okay?
Mm-hmm.
And the good doctor usually not only give them bath, they bathe them. And you offer empathy
Yeah.
for the E, and you would say something like that. God, so many people feel the same way you do.
Mm-hmm.
Okay? And then you elicited what solution they would bring, because you're not, and then you would either support or correcting a little bit, not only offering suggestion. And that works a little bit. If you're interested, you can pick up a lot of, because people open up.
Yeah. Yeah.
They said, what's going on in your life? Wow, I went through this divorce, it's killing me, and blah, 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 blah. So that's, but believe it or not, this didn't really take hold in primary care.
Mm-hmm. Mm-hmm.
I used to teach at Bayfront, okay, my resident. And it's just like, we don't have time for this stuff, okay? So it's getting worse with technology, because now we don't have access to the patient as we used to.
Yeah.
We have access to the computer.
Yeah, right. You're seeing it, right? But I think that primary care is important. And, I shared with you prior to us coming on here, right, is that we know that a lot of the biomedical conditions that people experience can be trauma-based, right?
Absolutely. That's a background.
Yeah, there's background, right? And so I think for the Black and Brown community, we don't always see it that way. We haven't had a basis for getting that information out to our communities, right? But we have a platform now, right? We're getting it there, but we're learning to identify the traumas that we experience.
It is so difficult. You have economic factor, you have all those psychosocial trouble, challenges that African American have to deal with, or poor people have to deal with.
Yeah, not just in our families of origin, but in the communities, right? And we are known for going and saying everything's fine, we're doing good, but our bodies are experiencing that trauma, right?
Now, let me ask you this quickly: Is in your opinion, is just cognitive behavior therapy, or CBT, is that effective?
I do believe that it is effective. It's interesting to me because we notice that some of the unhealthy thought patterns that individuals carry are community-wide and nationwide, right? We have a lot of unhealthy thought processes that appear normal because everyone thinks that way, right? But it's not healthy to carry a lot of those thoughts, right? Sometimes what happens is we feel inadequate when we carry those thoughts. We feel as though, we compare ourselves to other people. We increase our depressiveness. We increase our insecurities when we carry certain thought processes with us.
Well, some of the neuroscientists now have been actually studying this stuff, and they said there is a natural negativity bias. So when faced in any situation, the first thing we think about is some horrible stuff.
Yeah.
The worst case scenario.
And sometimes based off of, we want to validate people's experience, right? We have had, the brain is interesting because as we grow from babies to adolescents to adults, we really are making sense of the world. And what we know works, we redo, right? What we don't work, you touch that hot stove, people like to say, you tend not to do it again. You might do it by accident, but you won't intentionally do it, right?
Correct.
And so you're right. When we see that bad things happen all the time, especially when we're exposed to environments where a lot of bad things happen to people,
I think it's normal.
Are that negative bias increases, right? So it's going to be a little more difficult to challenge it. But really, that's where we start to talk about what does your support look like, right? Maybe you need a new support or a different environment. And that can be hard for people.
There's a new kid on the block.
Yeah.
It's the same thing. Is the instead of CBT now it's DBT.
Okay. Dialectical
behavioral therapy. And actually, yesterday the two researchers from Harvard Medical School published this called DBT for Dummies.
Okay.
And it's within 24 hours at Amazon bestseller.
Really? I did know that, right? I know Lanahan is an expert in that because she writes a DBT manual, does like trainings and certifications, and
Correct.
it has been something people have used a lot for individuals who are living with borderline personality disorder. Has a lot of distress tolerance skills for helping people who may engage in self-injurious behaviors.
Do you have a few of those borderline personality disorder?
I have met some individuals, but I think I meet some very seasoned in life people, right? They are good people, but they have some things, and so personality disorders are a whole different ballpark.
Well,
right? But to your point, I think it's important, since we are talking about depression, is that again knowing our history, because we know that a lot of this stuff co-occurs, right? You can be living with a depressive disorder and also be living with a personality disorder. We have co-occurring. You can be living with a depressive disorder and also a substance use disorder. And it's always important to me, just because, my background has been in working with individuals with substance use disorders as
Correct.
well, is that I always ask about substance misuse, especially for depressive disorders, because alcohol is a depressant. I know the world likes to call it happy hour, but it's the worst if you're living with a depressive disorder, right?
Absolutely.
And it's not okay to say, well, I stopped taking my meds so I could drink, because it's not how the medication
No, it doesn't
works.
work that way.
Right.
And
And it's not okay to go, well, it helps me sleep, because we know that it's really just cutting all the lights off in our bodies when we do that, right? So what can we do different?
let me ask you this. Is there a particular profile of patient that would match a particular therapy that you assess that beforehand? In other words, psychodynamic for this person who never get better or whatever, or you're gonna use. Most people use CBT, a lot of like that. Any experience with that?
I think that whenever you're thinking about identifying, if this is a clinician, right? If you're thinking about what approach to use, you want to look at what's in the client's best interest, right? Because it's easy for us to go with what I like to do.
It's not so much that you like to do, but you have the knowledge, and then you find out about the patient. Yes, because if you tell the patient that stop smoking, go to sleep on a regular basis, and exercise, it may not be something that patient can do.
Yes.
Okay. I mean, that's where we faulted sometime in primary care, because total lifestyle changes is not easy.
Yeah, but solution focus is also appropriate, right? So sometimes people are coming in and we really need to look at what is it that's going to help you move forward in this moment. Us as therapists, sometimes we want to dig into the trauma, but if the trauma is not currently impairing their functioning to a level, right, we know that when
destructive,
yes, and when we unmask that, there could be some emotional flooding. Do we need to do that right now, right? Sometimes we don't need to do that.
You don't want to explode the grenade.
Yeah, what we need to do is say, okay, it seems like you really only have a limited time to be in therapy for whatever reasons. Maybe you're moving soon, whatever. You're a parent, you don't have the capacity for certain things right now. What can we do to help you move forward in your life? So that's more of a solution-focused approach. And that can be up to like 6 sessions, right? Because I know,
the time.
Right, the time frame is very important. And I think that what overwhelms people is feeling like they have to be, I like to joke and say that, when we went through school, we got told as clinicians it was going to be like Freud. You're going to have a nice, cute couch.
Absolutely.
and see people for 3 years.
That's why I say, hey, almost time out here. Okay.
right. And that can be overwhelming. Like you're saying, I have to be in for 3 years. Well, something must be wrong with me, right? So we don't want people to feel overwhelmed with the self-work. It is a constant process, right? I always talk about, like, for myself, it's important for me to relook at who I am and what I'm doing, what my self-care practices look like, because I am busy, right?
Absolutely.
But same for our clients. We have to recognize that it's an ongoing process, and we're not going to get through all of it right now. We're just going to improve your current functioning in areas where it may not be the best.
Now, is there one therapy that fits all?
There is not one therapy that fits all.
Okay.
There is not one therapy that fits all.
And so what do you do when somebody actually need medications? Or do you?
What do I do?
In other words, do you believe that medication helps?
I do believe that for certain individuals, medication helps.
Okay.
And so, I am not I am more of a holistic person personally. And that is my own personal choice, right?
Okay.
But I recognize that there are some disorders, so individuals living with bipolar disorder, right? It's more effective for them to manage their symptoms when they are in therapy. And
we are not talking about bipolar
we are not.
depression.
I want to give an example, right? Because
I understand. I understand.
But I know what
that's
you're
a tough
saying,
one.
right? That's a tough one, right?
Yeah.
But being someone who has worked with substance use disorders for a long time, I always caution people. Now, if they come in on medications, I always say, hey, make sure you're communicating with your provider about what's truly going on with you, and never stop anything without talking to them.
Oh, absolutely.
It's important, that kind of thing, right?
Yeah.
But I also screen for individuals who may come in and have more of a tendency to give up their own ability to manage their symptoms, right? So this almost this sense of a quick fix, like I can just pull up to a McDonald's and cure my depression in some way, right? Instead of looking at how can I work through it, like what does your sleep routine look like? Are you even setting yourself up to get good sleep at night?
Correct.
What does your exercise routine look like, right? So there's been studies that have shown, even if it's not high intensity, if you're working out, if you're doing some type of exercise at least an hour a week, it serves as a protective factor against depression, right? So what is life looking like, right? Because medication isn't going to solve that you go home to a bad environment.
Or fix your thoughts.
Right. So, it's important that people consider what's best for them. And for some people, medication is appropriate and there's no shame in that. And there are some that you may be able, with mild symptoms, you may be able to manage it with just working.
Well, let me admit to you, as a primary care physician, yes, I treat a lot of patients with SSRI and SNRI. And, there's some good success in terms of stabilizing their physical symptoms and controlling their anxiety a little bit like this. But there's a lot of side effects sometimes associated with this. People gain weight, they lost their sex drive.
Yes.
And in the long run, if you don't provide a framework for the patients to access, so what happened when they leave therapy? Because it's a learning process. That's why I kind of, when I was looking into the DBT stuff, and you got to actually teach the patients, you got to hopefully get them involved in some of those techniques that they can learn. And for me, whatever little success they make, I encourage it. Okay, because this stuff is. For instance, we're going to talk about lifestyle, but I'm not going to talk about lifestyle because we're almost out of time.
But that's important. That's an important piece to
absolutely. But I'll tell you what. Honestly, now there are so many evidence out there that just walking. Walking is so dynamic and so beneficial. And, I was going to do a talk on walk, but I said, man, people are going to laugh at me. Just like I do a talk on breathing.
Yeah. Oh, when I talk to people about teaching them how to breathe, they go, I know how to breathe. Why are we going through this?
You have to teach me how to breathe. I said, most people actually have shallow breathing.
They're not focusing on your breathing.
Correct.
Yeah.
And that's the most important thing.
You need oxygen, right? You need it.
No. The next breath is life.
Yeah.
If you don't bring the next breath in.
Yeah, I like that.
3 minutes.
Right. But, so I love you saying that because, therapy is really about looking at what your lifestyle looks like, not just challenging those thoughts, but getting you to get back with your breathing.
That's a holistic aspect, aspect of it.
Because those things are going to help you, and especially, when you can't get to your primary care and get that refill, you want to have skills to manage your mood so that you're not flying off, right? Because we see so many people who end up in jail, who end up with all kinds of cases and problems as a result of not managing their mood.
Doctor, time is flew.
Are we there already?
Time was flew.
Oh my gosh.
Any take-home message for the patient? Any last famous word or advice or recommend? Because we may have to do this another show.
Yeah. Of course. I think we have to. I had no idea time was going to fly so quickly.
It is. Yeah, I'm looking. Well, you already checked me out because I have another show.
Oh, at 6:30. Yeah. I what I will say is that there are many resources. So the Well for Life is located off 22nd, and so please, it is a Black and Brown community, holistic. We heal down at the Well for Life, so make sure you do that as well. Of course, my business is Center for Wellness, and there are multiple community partners that are vested in healing Black and Brown. Brother John has been talking about that in his community. Antonio the Barber has been doing that. Pinellas County Urban League is definitely providing services and supports. So we want to make sure that everyone knows that we are vested in them and that it is okay to not be okay.
Doctor, I am going to find you to come back here again because this is interesting.
You have to look far.
We miss a lot of stuff here, but I really appreciate you being here and then over having that conversation. Thank you very much. Okay. And hope folks out there, if you have any question, please give us a call. Let me see if I can remember the number, 727-637-2416. Give us some feedback about what you heard tonight. And obviously, this is a long, complicated subject. So hopefully we can plan another session to talk about the treatment of depression. Thank you, Doctor.